In this video, I am going to show you how to read an ECG in an easy systematic way so that you don't miss common abnormalities seen in ED and the ward. Start by calculating the rate. It is done by dividing 300 by the number of large boxes between two R waves. It can be normal, which is 60 to 100, it can be less than 60, or it can be more than 100. If less than 60, look for the P wave. If P wave is present, check if each P wave is followed by QRS. If yes, check for the PR interval. If it is less than 0.2 seconds, your diagnosis is sinus bradycardia. If more than 0.2 seconds, your diagnosis is first degree heart block. If the P wave is present, but each P wave is not followed by QRS, there are three possibilities. PR interval prolongs serially, and then there is a skipping of a beat. This is Mobitz type 1 block. PR interval is constantly prolonged, and there is a sudden skipping of beat. This is Mobitz type 2 block. There is complete dissociation between P and Q waves. This is third degree block or complete heart block. If the P wave is absent, this means that SA node is not acting as a pacemaker. In this case, look for the QRS. If the QRS is narrow, this means that the AV node is acting as a pacemaker and it is called junctional rhythm. If the QRS is wide, a foci in the ventricle is acting as a pacemaker and this is called ventricular escape rhythm. Now for a heart rate of more than 100, check the QRS morphology. If narrow, that is less than 0.12 seconds, check for rhythm. If the rhythm is regular, check for P waves. If P wave is present, it is sinus tachycardia, and if P wave is absent, it is paroxysmal supraventricular tachycardia. If rhythm is irregular and a P wave is absent, it is atrial fibrillation. If QRS is broad, that is more than 0.12 seconds, and the rhythm is regular, it is a ventricular tachycardia. If the QRS varies in amplitude, axis, and duration, it is torsidis de pointis, and if there is no distinct P and QRS wave, this is ventricular fibrillation. Now that we have checked for conduction and rhythm defects, we will look at the morphology of individual waves. P waves are normally less than 2.5 mm tall and wide in lead 2. If more than 2.5 mm tall, it suggests right atrial enlargement, and common causes are pulmonary hypertension, tricuspid stenosis, and chronic lung disease. If more than 2.5 mm wide, it suggests left atrial enlargement. It is classically seen in mitral stenosis. QRS morphology can help diagnose bundle branch blocks. If it is M-shaped in lead V1 and W-shaped in lead V6, it suggests a right bundle branch block. And if it is W-shaped in V1 and M-shaped in V6, it suggests a left bundle branch block. ST segment changes can be used to diagnose myocardial infarction. ST elevation in V1 to V4 suggests an anterior wall MI. ST elevation in 2, 3 and AVF suggests an inferior wall MI. And in leads V5, V6, 1 and AVL suggests lateral wall MI. The last thing to cover is potassium abnormalities, which commonly cause ECG changes. Hyperkalemia is characterized by flat P waves, prolonged PR, wide QRS, and tall T waves. Hypokalemia is characterized by tall P waves, ST depression, and flat T waves. If you read an ECG using this approach, you will not miss any important diagnosis. If you found the video helpful, hit that like button and subscribe to my channel, and I will see you in the next one.